IT band. It can be a hip flexor, a medial rotator, and an abductor. Again, there's a soft tissue component and then the tendinous portion, IT tract. Sartorius, longest muscle in the body, correct, Miss A?
Yes.
Flexes the hip, laterally rotates the hip, abducts the hip, flexes the knee, medially rotates the knee, starts at a SIS, and comes inferior medially to that Pezanserine region, all the way across the hip here. Long ribbon-like muscle, frequently gets irritated overuse. So if you look at the back of the knee, you take your hand, so this would be medial here, medial up here, lateral down here. Yeah. So we've got the parts here of the Pezanserine, and then the two lateral biceps and the IT tract laterally. Pretty easily identified tendons in the back there. Lateral rotators. I'll cut you guys some slack on this. Piriformis, you've got to know. Origin, insertion, action, innervation. This is the majority of what you're going to see when you're talking about lateral rotation. It's the largest of these muscles, and it's still not very big. Anybody had piriformis syndrome or see anybody with it? Yeah. So I think it's 91% of individuals, the sciatic nerve goes underneath this muscle, okay? And the other 9%, it pierces this muscle. So if you've got a tight piriformis, it's very common to get sciatic nerve inflammation, irritation, and symptoms as a result. So this is something that you're gonna see a lot in the running population. People who are active tend to have this a little bit more. If you see somebody that walks with a toe out, you're gonna think, okay, external rotators are gonna be tight. This is where you're gonna wanna focus. Quadriceps femoris, again, is also a lateral rotator coming off of the ischial tuberosity, moving this way. I will make you a deal. As long as you know that it's part of the group, quadratus femoris, obturator internus, externus, and the Gemelli brothers, superior and inferior. Do not have to know origin, insertion, and innervation, just the action of those four, of those five, rather. Is that a deal?
Yes.
You good with that? Any objections?
Denied.
No.
Maybe quiet now.
Again, they all run parallel to one another. They're just very small, like, you're never gonna treat an individualized Gemelli superior strain. It doesn't exist. There's no way to differentiate that other than maybe if you had somebody who had MRI. And again, you're not gonna treat it any differently because they all do the same action. They're all hip rotators, external rotators. So that goes from piriformis, you gotta know, quadratus femoris, obturators, and then gemellus. Iliopsoas, this one you will see a lot. Deep hip flexor here. Iliopsoas. Okay. P is silent. But it's there, so don't forget it in the spelling, right? You're gonna take, it comes off of the ilium, and the psoas major here. So this is a combination of the two muscles here. Deep hip flexor. Anybody had a hip flexor strain? Not fun at all. None of these are any good. These are all very painful. very debilitating. So if we look at them individually, psoas major is going to originate the bodies and transverse process of the lumbar vertebrae. So all the way up here at L1, L2, all the way down the lumbar vertebrae. So how in the world do you get to this muscle? We'll have fun palpating this tomorrow. Don't eat a real heavy meal in the morning. So it's going to combine, again, very deep structure, and will come down and attach at the lesser trochanter of the femur. So again, big hip flexor here. Iliacus is going to come right off the iliac crest and the fossa here in front to that same lesser trochanter. Then this psoas major, psoas minor. There it is. Okay. Well, anyway, just know that the iliopsoas as a muscle, as a group, includes these three. Psoas minor, psoas major, and iliacus. We travel a long way.
So the minor's not in the.
It's not in the PowerPoint. It seems odd. It has a branch that comes down and attaches to the pubis. Again, I always thought that was part of the iliopsoas. I'll look that up. It's an inguinal triangle, inguinal ligament, sartorius, and the adductor longus are going to make up this triangle in the groin region. Within that, we'll talk more about what structures lie in there, but you've got neurovascular structures that are going to be very important there. Talk about that tomorrow. I do not expect you guys to know every ligament that's listed on here, but what I want you to appreciate, because we don't have a gross anatomy section, is this dissection here takes forever. You cannot imagine how thick these ligaments are, okay? So if we're looking at a pelvis, and you're gonna hear a lot of people talk about how the SI joint, sacroiliac joint, so the sacrum and the ilium here, you're gonna hear a lot of people talking about how the SI joint is extremely mobile and you get all these up slips, down slips, rotations, nutations, all this kind of thing. I'm gonna tell you right now, I have dissected these. You cannot imagine how thick this stuff is, okay? So this is an inherently stable joint. Now, I'm not saying that it can't get out of whack. It can. You can have muscle imbalances. You could even have a dislocation or a subluxation or something like that. But it will take a tremendous amount of trauma for that to occur. So the times that I have seen actual displaced pelvis with SI problems, somebody hits a tree head on and they've got their foot mashed to the brake trying to stop the car. They hit the tree and it just takes them and just, you can imagine the trauma that occurs with something like that. I've seen a person fall off of a roof and land on one side and it does this kind of thing, but it takes a lot, okay? So don't, again, patients are gonna come tell you all the time, because this is all over the internet, my SI's out of whack. Well, it might be, but it's not dislocated, people. Don't buy into that, right? Super stable, super thick connective tissue here, all right? There are therapists that all they do is treat this joint, okay? And there are people that are really good at it, but I really question when they say, oh, that this is tip this way, it is, I just don't believe that occurs. I do think there's plenty of room for, inflammatory problems, muscle imbalances, tightness, all kinds of things that we have everywhere else. But again, I struggle to see all this stuff that you're gonna hear about it. So I'm just letting you know. That was Dr. Levin bias there. Again, super thick anterior structures here, anterior sacroiliac ligament, pubic symphysis. You've got a disc in between your pubic bones in the front. I have seen that disrupted. That is exceptionally painful. And again, most of these are going to occur with some type of high velocity motor vehicle accident or some type of fall. It's pretty hard to dislocate these things with just, say, running or other things that you're going to see in the lower half, injury-wise. The hip joint also has fairly thick ligaments, and again, an inherently stable joint because of the congruency of the ball and socket. You've got a really, really good fit here. In almost 30 years of doing this, I've seen 2 hip dislocations. One of them I was standing right in front of on the sideline of football, where a kid was moving laterally this way and he gets hit right here, and he was out before he hit the ground. I could see his eyes. He just rolled back like this and hit it. Took us 45 minutes to get him stable and get transported.
Why was he knocked out?
Because of the pain from hip dislocation. Yeah, it's gruesome. Gruesome. But again, it doesn't happen very often. Not very often at all. And again, it's due to the structure, and then you got the ligament that's around here. So very, very stable. You talk about the ball and socket of the shoulder. We talk about how many dislocations that they have versus the hip. It's not even close. Okay, inherently stable ball and socket versus the shoulder, inherently unstable. So here's some of the neurovascular structures I was alluding to in this inguinal ligament and the inguinal triangle here. We've got both the femoral artery and the femoral vein. So if someone gets hit here in the groin, punctured, lacerated, shot, whatever, they bleed out exceptionally quickly because of that femoral artery right there. So that's when you do have to apply pressure immediately if you ever saw something like that. Hopefully you don't ever see that. But you've got the nerve here running laterally to the vascular structures. Inguinal ligament running kind of in this direction, this diagonal direction here. Again, sartorius is going to be the inferior part of the triangle, and then the adductor longus here. Running pretty much north and south here. These are lymph nodes through here as well, so you'll see a lot of times when people have some type of systemic infection, they will get very tender in this area as well. So swelling can occur, gets to be pretty uncomfortable for them. Mobility becomes a problem as well then. We talked a little bit about the sciatic nerve. Again, take your index finger. It's about how thick the sciatic nerve is as it passes through the hip musculature, okay? It starts to branch off after that, but it's super thick. I mean, you can imagine how that nerve gets impacted. Anybody suffered from sciatic? You guys are too young. Ah, Miss Ann and Cam, this is no fun. That is a life-changing type of thing. Miserable pain. Connective tissue structures. Okay, so ligament of nuchae going from the occiput all the way down, supraspinous ligament between each spinous process. And then you've got this whole bunch of ligaments down here. Again, don't worry about identifying those. I'm not going to require that. I just want you to appreciate the thickness and the vast network that occurs down here. All right, so again, lots of palpable